Welcome to Gilda's Club Kansas City and our LGBTQ panel and healthcare. We really appreciate having you all here. I'm Clara Anderson Sante. I'm the Director of Diversity, Equity, Inclusion, and Programs. My pronouns are she, her. I've been with the organization for about 7+ years, and we're very, very excited to pull together such a wonderful panel and have so much great community support tonight to learn and to grow. And I'm going to turn it over to Sam, who's our MSW intern, who's going to kind of lead our moderation of the talk tonight. Go ahead, Sam.
Hello, friends and colleagues. So as Clara mentioned, my name is Sam Hayes. I personally identify as a queer bisexual woman. So this panel has been of great interest to me. I'm also the current Master of Social Work student intern for Gilda's Club Kansas City, so I am a first year in my master's program. A bit of Zoom housekeeping notes, just so we can keep those in the back of our mind. Like Clara mentioned, all audience members, please keep your cameras off and your microphones muted until we reach the Q&A portion of the evening, and this will be the latter half of our time together. This is just to keep the focus on our wonderful panelists who have so graciously donated their time to be with us this evening. So with us tonight, and I will introduce their names and pronouns and then give them some space to really explain their work and their community involvement. But with us, we have Michelle Veras, who uses she, her pronouns, Adam Douri, he, him pronouns, and Tori Gleason, who uses she, her pronouns. So I will turn it over to Michelle first, if she is so comfortable. So if you could please just introduce yourself and share your connection to the LGBTQ or queer community. And or your role in the healthcare community as well.
Sure. Thanks for having me. It's great to be here with you all tonight. So my name is Michelle Veras, and I'm the projects director at the National LGBT Cancer Network. Our organization has been around for about 12 years now, and we really work to kind of ensure that three things happen. We educate our communities about our increased risk of cancer. We train healthcare providers and a variety of other audiences on how to create safe and welcoming spaces for LGBTQ folks. And we advocate for our communities in mainstream cancer research. And so while I don't have a personal connection to cancer, I do identify as a queer Latina and have been involved in community health work for a really long time. And so when I came to the Cancer Network in 2018, was really excited to be able to work on some of the projects and policies that impact cancer care at the national level.
Wonderful, thank you. Adam, would you be able to share?
Sure thing. Hi, everyone. My name is Adam Douri, and I'm a project lead with Syneos Health, which is a contract research organization. I'm specifically focused on delivering new hematological and oncology therapies to patients across the globe. My connection to the LGBT community, I identify as a gay first-generation Arab Muslim American. So I'm really excited to be here tonight and to speak with you all.
Awesome, thank you, Adam. Tori?
Hi, I'm Tori Gleason. I've been a chiropractor for the last 15 years, involved in hospital governance for the last 10 years on a critical access hospital board. I'm a member of the Masonic Cancer Alliance Community Advisory Board, and I serve for Equality Kansas, the 501c3 and 501c4 boards, and also on Wichita LGBTQ Health Coalition. I'm trans, I'm queer, and here we go. Let's do this.
Stunning. Thank you, Tori. So in no particular order, so our panelists feel free to answer if the question speaks to you, but we'll just jump right in if we're all ready. So really our first question is, in what ways can occupying an LGBTQ+ identity complicate navigating healthcare? And what are some specific difficulties that queer folks face in receiving their healthcare?
I will take that one to start, and then hopefully other folks can chime in. But I think that our organization, the work we do, a lot of what we see is that first, difference or inequity happens in seeking out preventative or screening care, right? So if you are an LGBTQ person, say living in a rural area, or just in an area where it's difficult to find welcoming providers or providers that are trained to, for example, address the healthcare needs of trans folks, I think that the inequities start very, very early.
Yeah, Michelle's exactly right. I mean, being open about one's LGBTQI, IA plus identity has complications on all sides of the exam room experience, right? There have been several studies that have been rooted in the contextualized sense of focusing on the minority stress theory that have explored the experiences of LGBTQIA individuals. If we approach this question from the eyes of like, an LGBTQIA patient, of which I would be one, there's, of course, the fear of prejudice, the lack of understanding, and the potential for inappropriate or misguided comments or questions from your provider. And nobody wants to be in that space, right? Regardless of if you're LGBTQIA or if you're a heterosexual cisgender individual. If we look at it from the eyes of a provider who identifies as LGBTQ, there was a really interesting paper, actually, if I remember correctly, by Lindsay Tolman from Wayne State University, exploring the experiences of LGBTQ medical students and how they navigated medical school. And these students reported witnessing medical school staff making prejudicial comments or anti-LGBTQ sentiments about their LGBT patients, asking LGBTQ students to also suppress their identities when meeting with patients or in front of their colleagues, and all reported that these experiences had an adverse effect not only on their mental health, but on their outlook on the healthcare profession, which is just shocking to me.
I guess it starts, and I agree with both of the presenters, it starts in the waiting room. It starts with your experience of, do you even feel seen? Do you feel welcome? Not even just affirmed, but welcome. I mean, too often, I sat through a symposium today and it was through Harvard, on basically how do we implement in LGBTQIA health, and how do we get that in the classroom? How do we get that into curriculum? And how do we get that in the clinic setting? And some of it is that we beg for competence, which should be such a low bar. The reality is what we need is to strike higher than that and say, we need affirmation. We need to feel seen, included. We need to feel that health equity is actually a mission-driven statement by an organization. And so when you don't even feel welcome on a form or through a patient portal, or being dead named at the front desk or the back office through insurance billing, how, all those experiences happen before you've even had a knee-to-knee conversation with your clinician or physician.
Absolutely. Does anyone on our panel have anything they'd like to add before we move to our next question? Alrighty. So our second question prepared is, cancer care can be very harshly gendered. So, for example, breast cancer for women. But we know that breast cancer can exist both in cisgender and transgender men. So how can we be more gender inclusive within the cancer community?
I can take that one. Essentially, we need to do better at messaging that all people have breast tissue and could potentially develop breast cancer. This is especially important because the risk of breast cancer among trans men, as well as non-binary people, is not really well understood. Much of what we do know is based on case reports. And these are, if you don't know what a case report is, it's a detailed report of the diagnosis, treatment, and follow-up of an individual patient. And we can't use those to generalize the experience across the community, right? So we can't take that case report and generalize it to the entire population, which means it doesn't allow us to understand the frequency of breast cancer in trans men and non-binary individuals. And it doesn't really do much to help us improve our education from that standpoint.
I'll just add to that. I think that when we talk about breast cancer, a lot of the imagery that we see is very pink and kind of this overt display of what our society views as feminine. And if you are a trans individual or non-binary, that is not going to be very welcoming to you. I mean, I identify as a cisgendered woman, and it's, I'm turned off by pink. I got a little card the other day that, I've recently turned 40 and it's time for my mammogram. And it was like a pink magnet with flowers on it. And I wanted to throw it in the trash. So thinking about just the patient materials that we're putting out, when we see the bright pink mammogram bands, those aren't going to be welcoming for folks that maybe identify as trans or gender non-binary. I also think that there are lots of assumptions made when we talk about breast and chest cancer. I was talking to some folks last week on another panel about this assumption that everyone wants reconstruction. And that folks that are going through breast or chest cancer treatment are often mandated to meet with a plastic surgeon to talk about that. And just, again, I think that a lot of our work lies in just not making assumptions about what patients want and not being afraid to have those conversations and ask questions.
Absolutely. To I guess catapult off of what the other two presenters said is that it's really about a patient-centered approach. What do they want? Language matters. Talking about breast tissue to a non-binary or a trans man can be very difficult to hear, and a lot of my trans men friends, when they go in for their mammograms, really struggle with that because it is such a gendered experience, at least the way it's especially in rural is tough. I live in a town with 3 stoplights when we only need 1, and so it's really difficult of an experience that, I mean, for weeks at a time in the approaching appointment, they're worried about it, they're stressed about it, and so that's all they could focus on. And so the reality is that understanding from their perspective, also just encouraging you to, if you haven't, form a DEI committee, get people in there that are non-binary, trans men, trans women, genderqueer, get people in there to get their experiences and to make improvements as a part of your hospital clinic setting. And I think that's the big thing, is that's how we have a cultural change. That's how we have an environmental change, is you've got to make sure that you get the people at the table that belong at the table.
Absolutely. Thank you. And as a fellow rural queer, I understand the occasional struggle. So one way we can make healthcare more inclusive, as you all mentioned, was changing the way that we format our patient intake forms. Has anyone on this panel been involved in these sort of changes in their practices?
So Clara and I are both members of the Kansas Cancer Partnership, which engages with practices across the state of Kansas to deliver better cancer care. Our intake forms for membership did not have a way to identify individuals in the way that they would like to be represented. So we banded together and got that form moving, and we're happy today to announce that we were successful in our endeavor. Now, I'm hoping that from that just member experience, that the providers involved would then take that back to their clinics and be ambassadors to continue this going forward, and take that critical eye, look at their own intake forms within their clinics and how they can better serve their patients.
And at the network, while we don't directly serve patients, it's something that we advise states and other organizations on. And so one of our best practices is doing the work to ensure that your forms are appropriately collecting information on sexual orientation and gender identity. And on our website, we have lots of resources about how to do that in the best way. There are a lot of places across the country that are really leading the way and have really great forms. And so it really is a matter of making sure that folks are bought in. everyone from the front desk staff to your providers, right? And that everyone knows how to use the form, and that providers actually having the conversation again, instead of making assumptions.
Absolutely. I think make sure that SOGI data is turned on your electronic medical record. It's really that simple. And a lot of these rural hospitals out here, even though the capabilities there, even though it's been mandated as a part of their EHR system, they don't even turn that portion on. And so making sure, and the pushback is always, and I've heard this being on the hospital board for 10 years, is that, oh, well, we don't want to ask those questions. We don't want to offend anyone. The Cahill 2014 study, 27, sorry, this is the Hayter 2017 study. They believe in the study, it was 78% of clinicians believe that people would refuse to ask the sexual orientation or answer the sexual orientation question. The reality was is only 10%. And so, and then of the Rulo et al., and I'll put these links in the chat here in just a minute, but basically that looked at patient attitudes towards being asked those questions. Only 3% of people reported being distressed. So if we're going to have a cow about 3%, I mean, we're going to miss too much when it comes to a health equity standpoint, making sure that we're properly screening our patients. And so just ask the question. It's really that simple.
Just to add to what Tori said, we do know that the majority of patients that identify as LGBTQ do want to be asked and do want to disclose. The problem is when we are not asked, it's like we're not seen, which, you know, gets back to a lot of what we talked about earlier. How do we enter that healthcare interaction feeling like we can bring our whole selves?
Yeah, and to add to that, you know, we need to do a better job of educating our providers and allied health colleagues and being able to have that conversation and to respond appropriately, because there are a number of studies out there where LGBTQ individuals have been asked how they felt when they, you know, responded to that question, and if they were met with any kind of discriminatory, you know, sentiments or disbelief, you know, in the fact, I can't tell you how many times I've heard this, well, you don't look gay. If they're met with that, they tend to withdraw, and that destroys that whole healthcare enterprise and exchange. And that's extremely important in our young adults. I mean, we already know that the move from pediatric care to adult care has its pitfalls in young adults, you know, from the lack of insured young adults to increased risk-taking behaviors, what have you. But all of those activities are exacerbated in LGBTQ young adults. And to add on top of that experience, they also, in some instances, report experiencing extreme periods of housing insecurity. And that is extremely, you know, just another layer of stress that's added to that whole exchange. So if a provider doesn't respond in kind, it just destroys that whole experience.
Absolutely. I stick out like a purple cow in a field of black and white cows. So I don't have passing privilege. I'm not blessed with that ability. And so plus my picture's in the front lobby. So it's pretty easy to find Waldo. And so the reality is that we know that patients, especially trans and non-binary patients, have horrible experiences. You know, about a third of those have horrible experiences in one study, up to 50% in another study, have horrible experiences in clinical settings. And a good portion of trans people won't even go back for just regular routine care. And again, if they won't go back, we're going to miss things. We can't get those preventative tests in there because they've had such a horrible traumatic experience. They just will refuse to go back to care.
Thank you. And thank you for providing those facts and statistics in the chat. Much appreciated, Tori. Does anyone else have anything they'd like to add to that question before we move to our next one? Alrighty. So it is important also to remember that individuals can occupy more than one identity. So how can one's other identities, so this is including race, gender, religion, etc., affect this intersection of cancer and LGBTQ affirmation, or healthcare and LGBTQ affirmation? I
think each of our panelists have hit on that in one form or another. at the root of the human experience, we want to be seen, we want to be heard, and we want to be understood. And if we feel like we're not having those needs met in our healthcare experience, we're less likely to engage, we're less likely to return, and we're more likely to have negative health outcomes in the end.
And I'll also say that on the data side, we don't know enough about folks, not only healthcare experiences, but specifically oncology experiences, folks that identify as LGBTQ and people of color. There isn't the data to understand that well, but we know all of the many disparities that exist when you identify with multiple I'm sorry, lost my train of thought there. But when you live at the intersection of multiple identities, we know that the barriers to care and discrimination you face just kind of increase the further away you get from being a cis white man in our society.
I think it's tough just because I just want to be seen. There's some identities that I'm a redneck country kid from Dodge City, Kansas. I mean, it doesn't get any more country than that. And so, it's tough. I grew up with an Irish Catholic father and a First Southern Baptist mother. I learned to not like myself at a very early age. And so it's just tough to navigate being different, being queer, being trans, being all these different identities. And heck, I struggle with it myself, let alone, how does someone else look at me? How does someone else deal with me from a healthcare perspective? And so it's just a difficult experience. And I just really, really respect the diversity we have in this panel here today.
So what are some ways in you all's various practices that you have witnessed really providers and professionals celebrating intersectional identities, or what ways would you like to see that happen in the future?
So I will say, and this is not necessarily about celebrating our identities, but I would like to see, and there needs to be an investment made in recruiting to the healthcare profession more folks of color, more LGBTQ folks. We know that we do better when we see and connect with folks who share identities with us. So I think that the more people of color we have as providers, more LGBTQ folks we have as providers, the better our populations are going to do.
Yeah, I think Michelle's exactly right. We're getting close to that moment where we can celebrate that intersectionality, but we're still trying to recognize ourselves in the healthcare service. And until we can all recognize ourselves, it's going to be tough for us to truly be able to celebrate.
I think one of the things I think is important is, and again, as they both alluded to, is being able to see yourself. Sometimes we have people that are part of the community that work at hospital and healthcare clinic settings that don't feel like they're even seen within their own facility, that they can't be gay, they can't be trans, they can't be queer or non-binary in their own setting. So it doesn't even feel like a safe place to work, let alone practice or be yourself. And I think it goes to a lot of things is, how can we support encouraging people to have an email signature with their pronouns in it, to introduce themselves. And if I introduce myself as, hi, my name's Tori Gleason, I use she, her pronouns, it's easy because I'm not asking, I'm setting that standard for somebody to know that, oh, it's a comfortable setting. It's a safe, affirming place that I can actually tell you what mine are. And so those little things like that, a pronoun pin that someone puts on their lanyard, or a lanyard that's rainbow colored, or something along those little lines that allow people to know, patients to know that, this is a safe place. I'm safe with this person. And so whatever we can do, and I know those are little things, but trust me, those of us in the community, we pick up on those things and we notice them very quickly. And so those little things make all the difference in the world.
Absolutely. So really along that vein of thought, really what we're going to need to be doing is rebuilding these relationships is what it sounds like. So what do you believe would be an effective or really appropriate way for healthcare providers or employees to regain the trust of members of the queer or LGBTQ community?
No, I'll take that to start with. Recently, our organization hosted a webinar around Pride seasons coming up in June in many parts of the country. And the conversation centered around how tobacco and cancer control programs at the state level could become involved in Pride celebrations. And I think that that is a really important first step to make. But allies and providers need to engage with our communities and see our communities the whole year, right? Not just in June. So we are seeing lots of places across the country where, for example, anti-trans laws are being passed. And so what does it look like for allies, folks working in healthcare, to step out and advocate for us? Again, not just at Pride, not just when they want us to come into their practice, but thinking about ways that folks can support our communities when we're frequently under attack still in 2021.
I think some of the other things too is, again, trying to get Goodland, Kansas to recognize queer people in more than 1 month, let alone any recognition at all. I'm going to call to allies. We need allies to do more than just like, yeah, you do you. Well, we need them to step up. We need them to demand that curriculum changes within medical schools, nursing schools, respiratory. It does not matter. You pick the alphabet soup behind the name and it needs to change. And that's what allyship looks like. It's more than just saying, yeah, I have trans friends. It comes with engagement. It comes with, when there's these horrible bills like you're seeing in Arkansas and Kansas and all across the nation, it comes with emailing your elected representatives. It comes with engaging with hospital administrators, because again, that's where a lot of our change has to happen. We've got clinicians that are there. We've got nurses that are there. Our struggle is getting healthcare administration, the C-suites, if you will, to actually buy in and understand that this is really life and death. This is about health equity. This is about saving people. And it's more than just the metrics or benchmarks you see in a boardroom.
Yeah, both panelists are exactly right. I can speak for myself only, but I'm really excited by the recent burst of clinical attention being paid to the needs of LGBTQ patients. But while this is a long overdue interest in the LGBTQ healthcare aims, we need to highlight, the important gaps and bring light to the serious issues associated with healthcare delivery for LGBTQ persons. This work can also, it's important to remember that this work can also inadvertently reinforce both the marginalization of sexual minorities and the cultural norms related to sexuality, gender identity, and the conventional family, right? So in an effort to ensure that positive outcomes come along for LGBTQ patients and make sure that they're paired with those noble intentions, I'm a big, strong, severe advocate for queer bioethics courses to be taught in our healthcare education centers. And for those of you who may not know what queer bioethics means, it's a methodology of scholastic, bioethical, and critical scrutiny that not only addresses the needs of LGBTQ persons in healthcare, but also considers the perspectives, histories, and the feelings of the community at large.
I think that's a really good segue into our next question, which before I move to, again, would any of our panelists like to speak to our previous one about rebuilding this relationship any further? Alrighty, just want to make sure no thoughts get left out. So great segue into As members of the LGBTQ community, how do you believe that allies should best support the community?
I think that with allies, and I kind of touched on this earlier, I like to skip ahead apparently. And so I think it's a matter of just making sure that we continue to engage and allow, here's the other thing too. Like when I started medically transitioning about 4 years ago, and I know some people hate that term, but the reality is that my entire community is transitioning with me and everyone is learning with me. And here's the thing, as long as you're not a jackass, I'm going to be pretty open about having a conversation. I'm N equals 1, so not everyone is like me, but I give a space for grace for people because I understand some people are just trying to understand. I'm the first trans person they've met in Western Kansas. And so again, there's a huge emotional, capital that's expended every day just because of the conversations that I navigate and other people in the SGM community. But the reality is that the allies that I work with and some people that did not understand, didn't get it, have been some of the best allies that I could ever have, that will email a senator, that will go to bat with an HR director at a facility around here, or a clinic or a hospital. And so building those relationships, it's that rapport, that need conversation and allowing a space for grace with people, I think is really important to building better allies, if you will, and for allies to really understand that, like, we're just people. That's it. Just pretty simple.
I'll add a little to that, but I think we've touched on some of these things prior. But if you are an ally and working in a healthcare setting, it's about making sure that your pronouns are in your email signature. It's about wearing that rainbow lanyard, and not being afraid to have the conversation and ask questions. And I so appreciate what Tori said about a moment of grace, because I think, so many of us are willing to, be vulnerable. We just want to be seen.
Yeah, exactly, Michelle and Tori. We want to be seen, we want to be heard, we want to be understood. And those little things that you do, like Tori said, and Michelle, we notice because we've been taught to seek safety. And those colors, those pronouns, those little things tell us that we're going to be safe, and we'll be safe with you, we'll be safe in that space. So we're always looking. I can't stress that enough.
Again, I absolutely understand that. I was looking for a place to be at home. Would any of you like to add to that or add to the note of allyship any further? Alrighty. So how should we move this diversity and inclusion conversation forward, particularly in the healthcare community? What perspectives do you feel like we are missing at this time, or what ways do you think that we can really just improve?
I think making sure that we, I guess sometimes I feel as a member of the section gender minority community, we're like that in the DEI space. It's like, oh yeah, them too. We're the them too. Like we're really good at like considering voices, and then we're kind of the forgotten or the miserable minority at times, because again, I get it, statistically, we are a small minority, but our voices still matter. And there's nothing worse than having a bunch of cisgendered old white men making decisions about us all the time, making those conversations and putting together, whether it be policies and procedures, curriculum, it does not matter. But we don't get a seat at the table. And yet those decisions directly impact not only our health, but just the way we navigate life. And so making sure that a diverse team is the best team, whether that be in a clinical setting, whether that be in a space of allyship, make sure that if you look around the room and everyone looks like you, there's a problem. You're missing a few people.
All right, and Tori's 100% right. If allyship to me means that you're making sure everyone is heard. So if you do look around that boardroom, or that executive suite or your staff dining area, and everybody is reflective of yourself, there's an issue. And I hope that in that moment, you take it upon yourself to do a little bit of construction in that moment and try to welcome people to the table that aren't reflective of yourself.
Alrighty, is there any other thoughts that would like to be added to that?
I think Tori and Adam covered that really well.
By all means, yeah, they did it. So now I would like you all just to dream big, really. So what do you hope that the healthcare community in Kansas City or in your area accomplishes regarding supporting the LGBTQ community and those individuals?
This is kind of like when they asked you to make a Christmas list for Santa. This is really hard. Like my dream list. Let's see. Making sure that sex and gender minority curriculum or queerriculum, if you look at Tulane and the way they call it, as well as Louisville and Harvard, is integrated into all of our healthcare settings. Making sure that eventually we can get protections in our local states that involve gender identity and gender expression for protections in there. I think the big thing is that making sure that it's not okay from a conversion stand. I know I'm going on a tangent. I go off in the weeds. I'm sorry to the other presenters, but making sure that conversion therapy is not okay. Listen, I'm going to be completely vulnerable with everyone here, and I do this a lot, but I attempted suicide in the 6th grade. That's not okay. You know, I'm coming up on 30 years since I attempted suicide. And the thing is that making sure that it's okay to be a gay kid, a trans kid, just to be who you are, and to not feel that hatred from the people around you, your neighbors, the people that say they love you on Sunday, but on Monday it feels a lot different. And so I think just realizing that, listen, some of us were just made different. That's all this is. And to be able to break bread with one another, to get to know one another, to make sure that people feel welcome in your communities, and whether it be your place of worship, whether it be your civic center, but just make sure that you realize that we're not any different. That's it.
And first, I would like to thank Tori for sharing. That was huge. Thank you for feeling vulnerable enough to share in this forum. But to add to that, you're 100% correct with everything that you've said. We need to make people feel safe. If we cannot have legislation that protects all individuals, if we cannot have education that goes just, and I'm going to take this a step further since this is our wish list, right? I want to see queer studies in all schools as part of all programs. If you're going to be in an undergraduate seeking a bachelor's of arts degree, I want to see queer studies as part of your curriculum for one of your humanities courses. That's what I want to see. Because I think until we're able to understand each other and learn to speak, even at a basic level, our language, things aren't going to change. And we're going to constantly be in this mode of building something and rebuilding it. And we don't want to keep that cyclic thing going. We need to build a strong foundation so that we all can live in a sturdy house.
I will add to that, even though I'm not from Kansas City. I really appreciate that, Tori and Adam. And Tori, again, thank you for sharing your experience with us. That's so powerful. I really like that you both started with this idea of curriculum, right? And starting early, because what I would like to see, not only in Kansas City, but across the country, is a day where I'm not asked a question about how healthcare providers can repair their relationships with our communities. That, you know, this inclusion and our care is just kind of part of what happens. And, you know, it's really disheartening to hear that folks are still living in states where they don't have protections.
Because it's Santa, I'm going to add one more thing in there. I think, you know, teaching kiddos, even in junior high and high school, about micro and macroaggressions, having unconscious bias training at an early age to let them know that, oh my gosh, I never thought of it this way. Because again, we all understand that from that implicit bias perspective. And it shouldn't have to wait till your first year of medical school before you finally get your first course in implicit bias. It should be part of onboarding at any facility you go work for. And not only just part of the onboarding process as an employee within a DEI perspective, it should be a regular yearly training thing through an HR company, through like, oh yeah, you know, I need to make sure that I'm aware of the lens that I see the world through. And I think that that's an important thing too, because again, it's bigger than that. It's bigger than just even our section gender minority. It's understanding from that intersectionality standpoint, you know, how we see people, how we judge things, how I was raised. I was raised in Dodge City, Kansas. Listen, there's some problems there just with that statement. And so, and making sure that we're aware and making our kids aware, whether it be, you know, as Adam said, in undergrad training and all the way through the curriculum. And so I think that's an important thing that we need to engage people with.
I think I'm gonna make that a hashtag curriculum. I like that. I like that. See, Sam,
I like
you
that.
just add into our entire wish list here.
And thank you all so much for building wish lists. And I just want to acknowledge that when you face this kind of discrimination and oppression every day, it can be hard to dream big. So thank you all for being a little vulnerable and allowing us to make those wishes for Santa. So we really are moving to our last question before we can go and launch into the Q&A. So our last question that we prepared is, how does undergoing gender affirming hormone therapy affect an individual's cancer treatment options?
So I'll start that one off. And here's the thing. And from a trans female perspective, if I had a diagnosis of cancer, it's not the biggest thing in my day. It's not really even a huge concern of mine. You know, housing insecurity, financial insecurity, all those things. If I had someone look at me and say, and again, we know this, there's data out there. Some surgeons will have someone take, you know, for 2 to 4 weeks prior to surgical procedures, they'll actually have them go off the gender affirming hormone therapy, typically estradiol. But some surgeons don't. There is, you know, is there a risk of VTE? Yes, there are those statistics that show that. Some of the statistics are limited based on the type of route of entry, whether it was transdermal, whether it was oral, whether it was actually injectable. And so a lot of those studies don't actually say the route that the estradiol was taken in. So it's kind of limited, but we know that those studies are there. But the reality is, I would have more problems with a physician telling me I needed to go off of estradiol, because again, I fought literally fought for my life and death, because I grew up in an era where there was no such thing as informed consent. I had to go through the model of 10 to 15 visits with a primary care physician, the behavioral health, to then get clearance, to get the okay, to then go see an endocrinologist or primary care physician. I was told no in college at K-State that I couldn't start HRT. I was told no at another clinic in behavioral health because I did not have access to care. And so it would kill me more, honestly, to have to go off of my estradiol than it would for cancer treatment, for my cancer diagnosis, for my staging of my cancer. You know, and here's the reality is that my mother died of cancer, my grandmother died of cancer, which is why I really feel an affiliation towards this community. And I know that, and my dad had cancer as well. And so again, there's cancer in my family. I know that. That being said, if I end up, and I'm one of the ones that ends up with breast cancer or something along those lines, the thought of even having breasts removed would be just traumatic as heck for me personally. I can't imagine a cisgender woman and how they might experience that. And I can only speak for myself. But understanding that having to come off of my meds for cancer treatment would be very traumatic for me personally. And I know of others that within the system that they've had similar experiences, is that for a doctor to look at somebody and just say, well, we need you to stop your estradiol, it's bigger than just, oh, you can't take your multivitamin, a couple of weeks before surgery. It's literally a life and death decision. And that could alone be something that is very traumatic, that could cause some unfortunate circumstances as well, and consequences that come with it. And so understanding that that's part of it.
Yeah, I'm right there with Tori. If we need to understand that when we make such a call, it goes beyond just patient safety or precaution. This can be perceived from the patient's perspective as a direct attack on their own identity. And if they're unable to take what is helping them realize their true self, it can have just dramatic, devastating effects on their mental health. And if we are not there to help address those, or armed with the artillery to help comfort that person in that moment, we're doing a disservice. And on top of that, we need a lot more data to back up what we're trying to decide here.
Just to add to what Adam said, we just don't have enough data. The data that we do have is largely from case studies. And so it's important to weigh the psychological distress that could have on the patient. And again, I feel like I continue to say this, but it's really about seeing us as whole people and being able to bring our whole selves into care, and considering what the impact of making a decision to come off hormones would be on a person's psychological well-being.
Is there any further notes before I explain how we're gonna do this Q&A?
I guess one other thing I'll add to that, just on anecdotally, as well as what we're seeing in the industry as well, is those trans people, those non-binary people that do opt to go for gender affirming hormone therapy, whether it be low dose or moderate dose, doesn't matter. Their depression scales and scores improve without even having an SSRI on board, without even having other types of medication. And so again, you're going to directly influence behavioral health just by removing that medication. And so we know that is and something we have to consider. And it's something that our social workers need to be aware of. It's something that they need to be prepped for and ready. It's something that that our primary care physicians and our oncology teams, they have to be prepped for as well. Because if they do make that decision that this is what we're going to do, from whether it's a risk mitigation strategy or a liability CYA strategy, whatever it might be, it is definitely in play. And so having those conversations and be, regardless of what decision is made, just be ready for the fallout that comes with it. So.
Thank you, Tori. So now that we have wrapped up our prepared questions, Clara, if you'd like to turn off the recording, you can feel free to.